Hello everyone! In the continuation of the Pemphigus, today in Dermatology Lectures, we are going to discuss Pemphigus Foliaceus and many other types of Pemphigus. So let's get started. Please subscribe to my channel. If you're watching my video for the first time, don't forget to like, subscribe, and click the bell icon for the notifications. The Pemphigus family are rare acquired autoimmune blistering diseases affecting the skin and mucous membranes. Pemphigus foliaceus is a rare, relatively benign form of pemphigus. It usually first manifests in adulthood, average 50 to 60 years, but childhood cases can occur. This type of pemphigus is less common than Pemphigus vulgaris, but in some parts of the world it is endemic and is very common. Endemic pemphigus is a form of Pemphigus foliaceus that occurs more often in South and Central America, particularly Brazil, where it is commonly known as Fogo salvagem. This form of disease often affects multiple family members. It appears to be set off by a virus transmitted by an insect bite. Pemphigus foliaceus is sometimes provoked by sun exposure, and multiple drugs have been found to be associated with the development of Pemphigus foliaceus. Patients with Pemphigus foliaceus develop scaly, crusted cutaneous erosions, often on an erythematous base. But they do not have clinically apparent mucosal involvement, even with widespread disease. The onset of the disease is often supple, but a few scattered crusted lesions that are transient and are frequently mistaken for impetigo. They are usually well demarcated and have a seborrheic distribution, that is, they favor the face, scalp, and upper trunk. Because the vesicle is so superficial and fragile, often only the resultant crust and scales are seen. The disease may stay localized for years, or it may develop rapidly and progress in some cases to generalized involvement and an exfoliative erythroderma. The Nikolsky sign is present. A common clinical finding in Pemphigus foliaceus is a positive Nikolsky sign. This is performed by applying shear stress to the affected skin, usually by rubbing the periphery of the existing primary or secondary lesions. If positive, this applied force will result in the separation of the upper epidermal layers from the underlying lower layers. This finding has been shown to be moderately sensitive but highly specific in diagnosing pemphigus. Here you can see in this diagram, the colored triangles represent the distribution of desmoglein 1 and desmoglein 3 in the skin and mucous membranes. Pemphigus foliaceus sera contain only anti-desmoglein 1 IgG, which causes superficial blisters in the skin, because desmoglein 3 functionally compensates for the impaired desmoglein 1 in the lower part of the epidermis. Whereas those antibodies do not cause blisters in the mucous membranes because cell-to-cell adhesion is mainly mediated by desmoglein 3. The histologic changes of Pemphigus foliaceus in early blisters in the Pemphigus foliaceus lesion have acantholysis in the upper epidermis, within or adjacent to the granular layer. Because the blisters are superficial and fragile, it is often difficult to obtain an intact lesion for histologic examination. As a result, acantholysis is sometimes difficult to detect, but usually a few acantholytic keratinocytes can be found attached to the roof or floor of the blister. Sometimes the blister cavity contains numerous acute inflammatory cells, particularly neutrophils. Eosinophilic spongiosis can be also seen in very early lesions of the Pemphigus foliaceus. The dermis shows a moderate number of inflammatory cells like eosinophils are often present. In some patients, Pemphigus foliaceus may be localized for many years. They do not necessarily have to be treated with systemic therapy, and superpotent topical corticosteroids may be sufficient to control the disease. Dapsone can also be used when neutrophils are dominant histologically. In active and extensive Pemphigus foliaceus, the treatment is as for Pemphigus vulgaris. The two main types of Pemphigus can be distinguished on the basis of clinical, histological, and immunopathological features. Pemphigus vulgaris has autoantibodies against desmoglein 3 and sometimes desmoglein 1, whereas Pemphigus foliaceus has autoantibodies against desmoglein 1. In Pemphigus vulgaris, there are deep blisters just above the basal cell layer, while in Pemphigus foliaceus there are superficial blisters, and blisters are below the stratum corneum. In contrast to the extensive oral lesions in Pemphigus vulgaris, it is extremely rare for patients with Pemphigus foliaceus to develop mucosal involvement. Generally, patients with Pemphigus foliaceus are not severely ill. However, they can experience burning and pain in association with the skin lesions. Pemphigus herpetiformis. It is an uncommon subtype of Pemphigus with atypical clinical, histological, and immunopathological findings. The exact mechanisms underlying pathogenesis remain unclear. Pemphigus herpetiformis appears to be an IgG-mediated autoantibody that mainly targets the desmoglein proteins of the epidermis. Target antigens for Pemphigus herpetiformis are usually desmoglein 1 and less commonly desmoglein 3. Peripheral blood eosinophilia may be found in some patients. Direct immunofluorescence staining on skin biopsy specimen is similar to the other forms of the Pemphigus. Interkeratinocytic deposits of the IgG and C3, most often seen in the superficial layers of the epidermis. Intense pruritus associated with urticarial plaques, vesiculobullous eruption in a herpetiform pattern, and the absence of mucosal involvement should be considered in diagnosing the disease. Pemphigus herpetiformis has a good prognosis and responds well to dapsone or low doses of steroids. However, some cases may progress into Pemphigus vulgaris or Pemphigus foliaceus. Drug-induced Pemphigus is diagnosed when a form of Pemphigus has been precipitated by a medication. Pemphigus may occur days, weeks, or as long as 6 months after the drug has been commenced. Drug-induced Pemphigus is usually caused by the induction of an immune reaction to desmoglein proteins, that is desmoglein 1 and 3, by thiol groups of medicines, which includes penicillamine, angiotensin-converting enzymes inhibitors, angiotensin receptor blockers, cephalosporins. Although most patients with drug-induced Pemphigus are shown to have autoantibodies against the same molecules involved in the sporadic Pemphigus, evidence suggests that some drugs may induce acantholysis without the production of antibodies. Most but not all patients with drug-induced Pemphigus go into remission after the offending drug is discontinued. Paraneoplastic Pemphigus. It is a rare immune-mediated condition that generally seems to be triggered by the presence of underlying neoplasm, benign or malignant. Hematological cancers such as non-Hodgkin lymphoma, Castleman tumor, chronic lymphocytic leukemia, Waldenstrom macroglobulinemia, Hodgkin's lymphoma, and monoclonal gammopathy, and other types of cancer and sarcoma, malignant and benign thymomas, and rarely others. Histopathological analysis shows intraepidermal acantholysis with the presence of necrotic keratinocyte cells, vacuolization of the basal layer, and dermic lichenoid inflammatory infiltrate. Direct immunofluorescence test usually shows granular linear IgG or C3 deposits in the epidermal intracellular spaces or at the dermoepidermal junction. IgA and IgM can also be detected. Antiplaquine antibodies can be present, desmoplakin, periplakin, envoplakin, as well as antiplectin, anti-desmoglein 1 and 3 antibodies, antibullous pemphigoid 180, and antibullous pemphigoid 230 antibodies. Although this is an autoimmune process similar to Pemphigus vulgaris, there is much greater number of antibodies that are directed against many different antigenic targets of the oral respiratory genital mucosa as well as the skin. Cytotoxic T cells also may play a role in some cases. As a result, the presentation of this disease is much more severe than Pemphigus vulgaris. Paraneoplastic pemphigus may have overlapping clinical features with pemphigus, pemphigoid, erythema multiforme, and lichen planus. Affected patients may exhibit erythematous, lichenoid cutaneous papules, vesicles, and bullae. Severe conjunctivitis that may lead to scarring and pulmonary symptoms related to bronchiolitis obliterans. A variety of oral lesions can develop, like severe stomatitis, including hemorrhagic crusting of the vermilion zone of the lips, widespread shallowed ulcerations preceded by vesicles and bullae, and areas of erythema with lichenoid stria. Typically, the patient has already been diagnosed with lymphoma or leukemia, but in 1/3 of the reported cases, the appearance of the paraneoplastic pemphigus resulted in the discovery of the neoplasm. The condition can resolve if the cancer can be removed or cured. Treatment is otherwise difficult and largely just supportive, aimed at dressing the areas, pain relief, and managing secondary infections. 75 to 80% of the patients die from paraneoplastic pemphigus or from the underlying cancer. Now we will discuss IgA pemphigus. IgA pemphigus is a rare group of autoimmune intraepidermal blistering diseases presenting with a vesicular-pustular eruption, neutrophilic infiltration of the skin, and circulating IgA autoantibodies against the cell surface of the keratinocytes. No IgG autoantibodies are present. IgA pemphigus usually occurs in middle-aged or elderly persons. Two distinct types of IgA pemphigus has been described: the subcorneal pustular dermatosis type and the intraepidermal neutrophilic type. Patients with both types of IgA pemphigus present with flaccid vesicles or pustules on either erythematous or normal skin. The most common sites of involvement are axilla and groin, but lesions can also develop on the trunk and proximal extremities. Mucous membrane involvement is rare, and pruritus is often a significant symptom. IgA deposition on cell surfaces of epidermal keratinocytes is present in all cases, as shown by direct immunofluorescence microscopy, and many patients have detectable circulating IgA autoantibodies, as shown by indirect immunofluorescence microscopy. The characteristic histological feature in IgA pemphigus is formation of an intraepidermal pustule or vesicle. The contents of the pustules consist predominantly of neutrophils. Acantholysis is usually not seen. Depending on the level of intraepidermal pustule, IgA pemphigus is divided into two subtypes: subcorneal pustular dermatosis type and intraepidermal neutrophilic type. In the subcorneal pustular dermatosis type, pustules are located subcorneally in the upper epidermis, while in the intraepidermal neutrophilic type, suprabasilar pustules involving the lower or entire epidermis are present. In the subcorneal pustular dermatosis type, IgA autoantibodies tend to react against upper epidermal surfaces, while in the intraepidermal neutrophilic type, IgA autoantibodies are found throughout the epidermis. The subclass of IgA autoantibodies is exclusively IgA1. IgA autoantibodies in the subcorneal pustular dermatosis type were shown to recognize desmocollin 152, while the autoimmune targets of the intraepidermal neutrophilic type remain to be identified. A subtype of IgA pemphigus, patients have IgA autoantibodies directed against desmoglin 1 or desmoglin 3. Making the autoimmune targets of IgA pemphigus more heterogeneous. The exact pathogenic role of IgA autoantibodies in inducing pustular formation in IgA pemphigus remains to be cleared. In both types, the pustules tend to coalesce to form an annular, circinate pattern with crusts in the center of the lesion, although a sunflower-like configuration of the pustules is a characteristic sign of intraepidermal neutrophilic type. Dapsone is the drug of choice for most patients with IgA pemphigus, act by suppression of neutrophilic infiltration found in the disease. A clinical response usually occurs within 24 to 48 hours. Long-term treatment with dapsone should be observed for potential adverse effects, including hemolysis and methemoglobinemia. If dapsone is not well tolerated, sulfapyridine and acitretin are useful alternatives. Occasionally, those drugs are not effective and low to medium dose prednisone may be considered, as well as photochemotherapy PUVA or colchicine. Due to the rarity of the IgA pemphigus, various differential diagnoses should be considered when approaching the management and treatment of the condition. Classic subcorneal pustular dermatosis, also known as Sneddon-Wilkinson's disease, is a chronic dermatosis characterized by sterile pustular lesions that erupt in cyclical pattern. Similar to the subcorneal pustular subtype of IgA pemphigus, the pustular lesions found in Sneddon-Wilkinson's disease coalesce in an annular pattern and eventually burst to form crusted plaques. The two conditions even have the same area of distribution, favoring the groin, trunk, and axillae, and avoiding mucosal surfaces. Histological examination of Sneddon-Wilkinson's disease demonstrates perivascular infiltration of neutrophils and mild spongiosis. However, in contrast to IgA pemphigus, direct immunofluorescence of Sneddon-Wilkinson's disease will be negative for IgA deposits against adhesion molecules like desmocollin 1 that are key in the diagnosis of subcorneal pustular dermatosis subtype of IgA pemphigus. Another differential diagnosis to consider when managing a patient with suspected IgA pemphigus is Pemphigus foliaceus. Clinical differentiation between IgA pemphigus and Pemphigus foliaceus is nearly impossible. Thus, immunofluorescence is key in the diagnosis. Direct immunofluorescence of Pemphigus foliaceus demonstrates IgG autoantibodies against desmocollin 1, in contrast to the IgA deposits against desmocollin 1 found in IgA pemphigus. Thus, proper diagnosis, usually histology and immunofluorescence, is essential in the differentiation of these two conditions. Neonatal Pemphigus. It is a rare autoimmune blistering disease caused by transfer of maternal IgG autoantibodies to desmocollin 3 to the neonate through the placenta when the mother is affected with pemphigus. It is present in the infants born to a mother with serological evidence of both Pemphigus vulgaris and gestational pemphigoid. Clinical features include transient flaccid blisters and erosions on the skin, and sometimes mucous membranes are also involved. It resolves spontaneously within neonatal period and does not progress to adult disease. Let's have a quick recall of the target antigen and autoantibodies in specific diseases. This is all for today. Thank you everyone. Kindly subscribe to my channel and click the bell icon for the notifications. Keep watching Skin Doctor for you.